we're thrilled this year to partner with Kantar, who conducted a survey to retrieve some very important and interesting data around many of the topics that we're covering throughout the course of the two-day summit. Yesterday, we had a bunch of slides that had that data. This was one which is appropriate for this particular session on data and sort of its relationship to artificial intelligence. So I want to have you join me in welcoming to the stage an entire panel of pretty amazing rock stars for this next session. And Alfred Poor will be leading this discussion. Let's give him a round of applause.
Well, good morning. So we're here to discuss whether or not try to separate the hype from the fact about AI and data analytics and whether big data is going to be the savior of healthcare, as some of us believe it will be. I'm honored to be on stage with a wonderful, I've had the chance to talk with these people, so I know just how wonderful they are. You're about to find out. I'd like to introduce Chris Boone on the end here. He's Vice President for Global Medical Epidemiology and Big Data Analysis Lead for Pfizer. Knut Mager is Head of Global Data Privacy for Novartis. And Lynette Cook is the Global CEO of the Health Division for Kantar. And it's always good to try to, 5G is right now the great buzzword. And it's like the elephant, it's so many different things to so many different people. So I'd like to try to just sort of nail down a little bit about big data so we have a common frame of reference, which you're welcome to disagree with, but need to start somewhere. So for me, big data is driven by the quantified self. We have much more biometric data and history about individuals that we can use both to study the individual health, but also community health at large. And the difference and the advantage and the problem is that this data comes from many different sources. And so part of the challenge is bringing those sources together in a way that's meaningful and reliable, and then applying artificial intelligence to create algorithms that can tease out those golden needles of knowledge out of those big haystacks. So does that sound like a reasonable description? So a lot of us have read a lot of the hype about what this can do, but Lynette, what do you think the reality is? Is this a realistic goal that we can see great disruptive changes in healthcare due to big data?
Well, I think that it definitely is a realistic goal. I think that even the title of our session, and we talked about this a lot in preparation for this, is it the Holy Grail? Is AI or big data or whatever buzzword you want to use, is that the Holy Grail? And I think that we should step away from trying to achieve the Holy Grail and think about it as right now we're in the middle of a perfect storm. As you mentioned, 5G. We have more data than we know what to do with it. More and more consumers have a smartphone in their hand. That means we can pull information from them. We can also push information to them. And then we have new machine learning algorithms.
And on top of that, the incremental cost of data storage has approached zero. So we can keep we can keep everything forever and not have to worry about it.
And it's good for the environment if everything's up in the cloud. So, but like any perfect storm, we have an opportunity right now. So I think it's less about trying to achieve the Holy Grail, and it's more about trying to figure out how do we navigate through this together. No company can do it alone. Everybody in this room, is probably trying to figure out how can you disrupt or prevent yourselves from being disrupted in the healthcare industry. But the reality is we have to transform, and we have to do it together. And that's how we'll, take advantage of the opportunities from coming out of that perfect storm. And then I think the one thing that we have in common here, you'll see that we have very diverse backgrounds, but what we have in common is the patient, and we need to use the opportunities, through those analytics of aggregating a lot of information and analyzing it appropriately, so that we can illuminate the patient as a person and truly understand their whole ecosystem. So that's why I say the Holy Grail isn't just about curing something or finding, the best medicine. It's everything. It's understanding their ecosystem. Well, anyhow, I could keep going on. I should let these two chime in.
Well, so maybe what we need to do is break this down into manageable bites. I mean, you don't create a drug to cure all diseases, right? You create a drug to address a specific disease. And coming from a pharma point of view, Chris, how do you see an analogy there? Does it make sense to try to break down the AI tasks, the big data tasks, towards just focus in on a specific target and try to beat that one?
Yeah, I mean, I think that one of the big things that we learned over the last several years, as it pertains to AI specifically, is that it's not in and of itself a holy grail. So we have to really identify the use cases of where it's most applicable and relevant. We've engaged in a number of partnerships over the years where you may find a partner who says that our technology or our solution can address your entire drug life cycle if you want it to. Obviously, those things are not necessarily feasible, but we've gotten smarter, and I think that's just part of the process. So you get smarter, you identify specific and very targeted use cases of where it can be most relevant and most applicable. In one case, you think about the issue of identifying sites for clinical trials, for example. Analyzing the massive amounts of data that we have for historical data from many of the sites that we have, being able to predict site performance is a huge thing when it comes to clinical trial optimization. So I think that as long as we can be very targeted in the use cases for AI, then it ensures greater success. But if you're just thinking that somehow overnight you're going to see a complete transformation of the clinical trial process, I just don't think that's very realistic.
That's good. But so I come from an era where I remember GIGO, garbage in, garbage out.
Yeah.
And we're talking about data that comes from many sources. It's siloed in different things. And Knut, from your perspective, could you talk a little bit about how you see the problems of trying to, in a database term, normalizing the data, be able to merge disparate data sets so that it becomes useful and meaningful?
Yeah, so as I told you, I'm not a data scientist,
yeah,
right? So
understood.
I can't opine on that. So, but my perspective is that of a person working more in the regulatory field. So I run the privacy program. So the way I look at AI and big data integration in terms of being a holy grail, so I see a lot of structural concerns that need to be addressed, and that's maybe typical of a lawyer, right? You see the concerns, but then you need to find a way out. So as you define big data, it's pulling different data together, and you would want to do that if you look at specific use cases. You would want to do this at a global basis, right? And what we see is that there's no common framework that would allow data sharing. So the issue of interoperability is an issue that we have both on the technological data science side. So how do you get to clean data? How you go through the curation process and make it available for research within pharma, but then also ultimately generate use for the consumer, or as the consumer becomes a patient, for the patient and the healthcare professional. So that's a technological challenge, but it's also a regulatory challenge, yes. Right? So how do you create interoperability in a world where data privacy, mm-hmm. So patient data is seen as a fundamental human right in Europe, is seen more as a consumer protection issue in the US, is seen as like a tool to create competitive advantage in other economies, or where frameworks are mainly used to attract investment. So this type of interoperability, that's a real challenge.
Just to go a little deeper on what you were just talking about, do you see regulatory forces as being more of an impediment, or as something that encourages and steers this kind of work?
I think at the moment we are at the risk that they are more an impediment. Mm-hmm. So everybody talks about GDPR as so like the one harmonized European framework, but if you look at it in the health sector, it's not harmonized at all. It's very fragmented, and we still have different views in terms of how you consent on health data in Europe, how you structure your registries, how you can assess, pull data together. If you look at the US, it's completely different, right, with the lack of federal view on health data. HIPAA addresses only like a fragment, has a very unique regulatory approach to covered entities, which is not at all suitable for the world that you've been describing, right?
Sure.
So we will all be generating data about ourselves using various sensors which are not subject to HIPAA.
Sure. So Lynette, how do we address the issues of making the data useful and accessible?
Well, I think just building off of, the conversation of, regulatory being a potential barrier, it speaks to the importance of collaboration, because I do think that the technology is probably there to, make sure that the information is protected, and there is a way for us to curate it, make it consistent, to bring disparate data sets together. But it will require the technology experts to partner with the epidemiologists, with the clinicians, with the drug manufacturers. Everybody will need to be involved so that, we have the best brains behind protecting the data and the privacy and the efficiency, bringing in speed, the best minds behind making sure it's medically relevant. And then I think that we have to remember that the patient can play a role here, but we have to we have to translate it for the patient so they understand why it's beneficial to share information. Right now, we just, we tell a patient with diabetes, eat better, exercise more, and your HbA1c levels will be better. But they don't know what that means. They need to know that if they were diagnosed today, but they don't really feel the diabetes, what they'll feel 20 years from now, because they, if they don't do these things. And I think that we all keep talking about patient empowerment, but we need to empower them with the right information. And that's, again, big data can help us with that, to target them appropriately and translate things that will motivate them to do something different.
It's that,
Can I-
it's that psychological study they did with children, one marshmallow now or two marshmallows later. It's very hard to switch their behavior from one to the other.
It's funny because I think that I'm probably one of the few who actually thinks that, I don't think the regulators or the regulatory constraints are there as much as we place them there. I think that the regulators are in a very tough situation where they're trying to continuously modernize regulations to fit this rapidly evolving technological and digital environment that we all operate in. If you look at where we're a decade ago, we didn't have many of the technologies we have today, so I think that would be a tough situation for anyone. But I think that when I think about the greatest challenge to how we're moving forward, it's really the social, cultural transformation that has to take place. Right now, you have consumers and patients that are much more engaged as they should be. We're having many discussions around data ownership, and patients feel like, well, the data's mine. So what that does is necessitate discussion around, well, how do you engage from a clinical research perspective now this patient community who now owns and controls their own data? It does get into these very unique collaborations, or in many cases pre-competitive collaborations that pharma companies have with each other as well as with providers and payers and so on and so forth. So I think that as we start to think about the future of it, I think we need to focus a little less on interoperability, because I feel like we've been having that discussion for the last 10 to 15 years and it's a bit old to me. And I do believe the issues are there, but I think they can be addressed, and focus more on how do we educate the patient and consumer communities to be much more empowered in this paradigm, and then thus how do we adapt our business and operating models to fit that new paradigm.
Yeah, please.
If I may.
Yeah.
So I think this is fascinating because it mirrors the conversations that I think we have also in our companies, right? So there's data scientists on one side, and there are other disciplines on the other side. And it's very easy to run into misunderstandings and projections. So I have not been criticizing the regulators. I think regulators are doing a great job applying the law. It's the legal frameworks that are not interoperable, and we may like it or not, but they are not, and they are being applied by regulators who try to find a way. I agree with you completely that we're in the middle of a change process and that it's a multi-level change process. So it requires, as you said, collaboration and the ability to talk across disciplines. It will require, if we really think about patient empowerment, I agree with you, the notion of ownership and what does it mean? Does it mean control over who you share your data with, even your healthcare provider? Does it mean full control over your health records combined with your fitness data, behavioral data?
I don't think we know until we have discussion. That's the point. So I'm like, we need to actually engage in the dialogue.
Yeah.
I think right now there's this kind of sense of, I would rather not have that discussion. Let's just maintain the status quo and not even engage. And the problem is that we're not seeing anything move forth, and we're doubling down on this issue of interoperability. And so, of course, don't get me wrong, data quality is a very huge issue. And I think you will hear most data teams say that it is. And we spend the majority of the time on the data cleaning and all of that to get it to a point where we can actually do the analysis. But beyond that, when you talk about what does it take to really transform, and it's becoming the Holy Grail, as we've articulated in our title here, then we need to really get down to what would actually move the needle. And so I don't think this is anybody's fault. I'm just saying that I just think we need to advance the discussion.
It's a natural outcome of the developing forces. And we've seen this in other industries over and over and over again.
Right, and I was going to say that it's probably going to be somebody who's not in this room, doesn't have anything to do with healthcare right now, or maybe not even anything with technology. Who's going to come in, democratize the data, not worry about the regulatory, not worry about who has to work together, but figure out how do I integrate everything that's available.
Is there a Google out there on the horizon for this, or an Amazon that could
Or an
come
Uber.
in? Yeah, or an
right.
Uber
who's
who could
going to come in and disrupt and not worry about all this, the baggage that we've been worried about for years.
But it's uncomfortable for everyone, everyone
Right.
involved, right? We're
Yes.
talking about an industry that's been highly siloed and fragmented, as you mentioned earlier. We haven't played well together for all intents and purposes. But I think that now's the time to rethink how we engage with each other on a pre-competitive basis. I think about how do we best engage patients much earlier, even when it comes to drug development and the process and what that looks like. I mean, these are all things that we've struggled with, because we don't know where that fine line is.
Doesn't this all come down to trust? I mean,
Yeah,
one of the
of course.
reasons that data is siloed is, the individual family physician is hanging onto that data because he or she wants to know that it's good and isn't willing to cede control to anybody else to manage that for them.
Which is unfortunate because in the world of healthcare, more information, more data together actually allows us to get more precise and have more tailored, more personalized recommendations, as opposed to that individual physician who's just keeping their practice information.
So I've seen many hype cycles in my career, and we all know the curve. I'm just curious, where do you think we are on this cycle? Are we seeing any real gains from big data, artificial intelligence analysis of healthcare information? Are we still reaching where it might become real? Are we headed towards implementation? Just what do you think? So if you'd start with that, Lynette.
Well, I think we probably each have a different perspective, given what we go in and day out to do. And I would say that, for my business where our mission is to aggregate and analyze data and really illuminate that patient as a person, as I said earlier, I think we're just beginning to do that. We're just beginning to be able to access disparate data sets and find ways to bring them together. And then create the right programs to empower and truly educate and give patients the knowledge that they need. But health literacy is still too low. So I think that we're just at the beginning of that.
Cool. Canute?
Well, I would opine on privacy and sort of data ethics. That's certainly on top of the hype cycle right now. I don't know whether it's a good thing or a bad thing. So it's a good thing that we start to get into conversations. I think the more important question then is what type of topics do we need to have conversations about? And I think sort of building a patient-centric data system that allows patients as they are consumers to take better care of their health that do away with some of the asymmetries of information, knowledge and power that are part of the healthcare system, right? If you think about information, knowledge distribution between a patient and a healthcare professional, and payers and power distribution. So we have, if we really are talking about democratizing, we need to think, I agree, from the patient perspective, and also as industry, I think we have an obligation to make sure that we are not using the data to sort of fortify those asymmetries. Sorry, that's only partially asking your question, but I think, I've heard a lot about privacy now in those conferences, and I remember that 3 years ago, a panel like this would not have spoken about privacy, and someone like me would not have been invited. And I think it's essential that we rationalize the discussion and that we put really the patient at the center of our conversation.
So practical hype?
Well, let me first say, I don't envy Knut's job because he's leading privacy and it sucks. I can speak from my perspective, and it could be a data science guy, and I can say we can be as exploratory and experimental as possible, and we should, from my vantage point. But his vantage point is to say, no, we shouldn't do that. So that's where you're seeing the divergence, I guess, in our perspectives. So I have the same discussion with folks, and our privacy folks in our company too as well. But nonetheless, I mean, I don't know if I can view it as where we are in the hype cycle more so than the maturation continuum. I think it's probably better how I would frame it. I think that we are still trying to figure out the most appropriate use cases for where it can have the greatest impact. We talked about the AI scenario earlier. I think that it's just going to be some experimentation that has to take place for us to learn of what we're really capable of doing. And while at the same time we're trying to reskill the current talent that we have to meet these new demands, right? So I don't even think that we have the smarts, so to speak, to fully understand and analyze all the data that's been made available to us now, whether it be made through Lynette's organization or wherever it's coming from. The point of it is that we're trying to understand all that we can do and what is the art of the possible.
But are we seeing any consistent wins with this technology? I mean, obviously not all projects are going to work out. Some do. I mean, one of the ones that gets a lot of visibility, at least from the things I read, is the whole area of medical imaging, where machine learning has been able to do as well or better than humans at holding in its mind all the thousands of images and outcomes so that they can do a better job of diagnosing. I mean, are we going to be building on that kind of experience where we get more wins, or is it still Wild West and some things work and some things don't? Lynette, how do you feel about where that works for you?
Well, it's hard to argue whether or not that's a good thing, that we can diagnose with greater precision and speed. It still doesn't answer, has prevalence changed, and how can we prevent? Mm-hmm. So I think that it's only one piece. That's why saying AI is the Holy Grail of fixing everything. It still isn't going to cure breast cancer or prevent it from happening. And so I think that we should actually use AI to fine-tune tools that we already have, but they aren't going to be the answer to cutting out all the costs that we know we can't afford here in the U.S. And so we need to solve for some other issues that I think. But
wouldn't earlier diagnosis and save in terms of treatment for more successful outcomes, but even beyond that, some of this combined with other data could point towards indicators that would tell us that, we have a number of systems that now can predict that you're going to be sick a week before you get sick.
Well, sure. I think that some of the best examples of how technology and data have advanced, the study of health is in being able to identify more biomarkers that can help drive more prevention or earlier diagnosis. So I'd say those are some of the top early wins that come to mind.
So Knut, I've got a question for you. Is it really possible to protect an individual's data and still have empower that individual to have access to it?
There's the
So,
Holy Grail.
so you just said I have the difficult and
Yeah.
and boring job. I have to say no. So, but I think it's a very good conversation. So I would say today no. I have great hopes in privacy-enhancing technologies, so technologies that preserve utility of the data and still protect the identity of an individual. So outside of the sort of our space, it's differential privacy has been talked a lot about also on this conference, so where you add noise to the data. Homomorphic encryption seemed to be a way to preserve utility of the data, but preserve anonymity of the patient in the process. So I have hopes in privacy-enhancing technologies, but there are some dilemmas that we really need to solve, which is data scientists want all the data all the time, preserve them forever. One of the key principles of protecting patient privacy is data minimization, and so how do you reconcile that? How do you reconcile data minimization with the need of a patient to have a full record of her data? I think the answer is today, I think, no. And we need to invest more in terms of creating accountability and the technologies that will allow us to do that.
So Chris, I think you live in a world where data privacy is a little bit different because, I mean, if you're focusing on clinical trials, you kind of have a contract with the patient to share information in the first place. Does that color how you view the whole data privacy issue?
No, because I don't live on the clinical trial data side.
Oh,
I live
okay.
on the big data, the real world big data side of the clinical R&D perspective. And so what my charge is to elevate the use of big data earlier in the clinical development process as well as in clinical trials in lieu of the traditional clinical trial data. I mean, we know all the shortcomings with clinical trials itself and it not being sustainable and all these things. So really what we're trying to do is to identify alternative or innovative pathways to getting regulatory approval by using these big data sources. So to that point, what I'm saying is that I live on that side of the world. So that's why I have so many conversations with folks like Knut about these very important topics. And we're trying to find that natural compromise for both organizations because they, as they should, protecting the organization and the issue of privacy, but we have to push in order to see some progress and some innovation in this space. But I think, though, the issue of privacy, though, has been one that has been evolving, I think. I think if you ask people 10 years ago how would they define patient privacy and how they want to see their data protected, they would have given you a certain perspective on it. But if you ask those same individuals today, I think it would be slightly different. In some cases, vastly different. I think what patients want they want control. And they want transparency into how their data is being. So when you're saying privacy, that means somehow insular or closed off. I just think they want visibility and control in how their data is being used, especially when they hear that their data has been monetized in a certain way. All those things are drivers, I think, that make people uncomfortable.
On the other hand, there's the altruistic.
There are those, absolutely.
I'm participating in a community project that's going to benefit people,
Yeah,
even though it
absolutely.
may not benefit me.
Right.
Yeah.
Or they may be able to see what the benefits are. But I think also, I don't want us to get too hung up just on the, big data isn't just what we receive from the patient.
Right.
It's, it's the whole community, it's population data that we could use, and it's also not just the clinical information. We also need to look at
from Google searches. The CDC uses that to track outbreaks.
Right. Bring everything together, but also there's so much more to understand around social determinants of health, and it's not always the scan or the blood test type of data that we need to analyze. Certainly the real world evidence, but there's a lot more to what what either is impacting that disease and then impacting whether or not the patient's going to adhere to any treatment. So
that's a very important point. And we haven't discussed that because when we talk about the big data and big data analytics, Lynette's point around the social determinants is huge. I mean, obviously, there's many studies that talk about income level, educational level, geography, all play roles into access to care. or just the overall health status of certain populations. So these are things that we care about as well as we start to think about doing clinical trials and recruiting for clinical trials and so on and so forth. But also just when you start thinking about medication adherence and where you should be targeting interventions.
It's a big pie and a big puzzle. And again, that social determinant factors, those are data as well. And so
Exactly,
it's just a
exactly.
question of how do we merge them all and connect them all and help us all get better.
And technology, in so many ways, may be the connector. Like
Yeah.
you think about the people who want to participate in a clinical trial, but don't have the means to go and actually, attend. So maybe, as crazy as the autonomous cars, there could be a fleet of autonomous cars that take you to your doctor or to participate in the trials.
I think the takeaway for me is that there's a lot of work to be done. We're making progress, but we're probably pretty early on the pathway here. And there's a lot of moving parts to the puzzle. I want to thank you all so much for being so generous with your time this morning.
Thank you.
And thank you all.